I would like to welcome you to Local Regional Therapies for Treatment of GIST in the Liver. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I'm the Executive Director of the LifeRaf Group, and I'd like to introduce our presenter for today. Dr. Edward Kim is a professor of radiology and surgery and director of interventional oncology at Mount Sinai Health Systems under the Division of Interventional Radiology. He attended Rutgers Medical School and finished his interventional radiology training at Mount Sinai. Dr. Kim is a world-renowned interventional radiologist who focuses on minimally invasive treatments known as local regional therapies for the treatment of liver cancer. He has authored numerous influential peer-reviewed publications and runs multiple prospective clinical trials. He's been invited to be course director and faculty at numerous meetings throughout the world. He believes that best patient care is achieved through a multidisciplinary collaboration and helps lead the multidisciplinary tumor board at Mount Sinai, as well as helped institute multidisciplinary office hours with liver transplant, hepatology, and surgery. He's a thought leader in liver cancer, especially with regards to radioembolization, thermal ablation, and chemoembolization, as well as combination therapies with immune checkpoint inhibitors. I'd like to welcome him here today and transfer it over to him to begin the presentation.
Hi, everyone. It's truly an honor to be here. Today's lecture, I'm going to share about what we do, what interventional radiology is, what interventional oncology is, and what we can offer patients with metastatic disease from GIST. So these are my disclosures. So just to start off, what is interventional oncology? A lot of patients don't even know what interventional oncology, what interventional radiology is. I would say the easiest way to explain this is that it is a minimally invasive image-guided procedure for the treatment of cancer. And what are the objectives of what we offer? Really, it falls into three categories. Number one is just straight from our procedure, it's a curative intent. It rivals a surgical resection in certain cases, certainly not all cases, but in certain cases, it can rival surgical resection for curative intent. We can also use it as what we term neoadjuvant therapy, or something to aid patients so that they can get bridged, or what we call downstage, to transplantation or to surgical resection. And then lastly is, I think, the most common utilization of our therapies is for palliative intent. And palliative certainly doesn't mean that you're terminally ill per se, but it's that we prolong life, hopefully maintain quality of life with our local regional therapies. And these are just some of the societies that we're involved with, that I'm personally am involved with: Society of Interventional Radiology and Society of Interventional Oncology. So what are some of the technologies or therapies that we're going to talk about today? Thermal ablation, better known as microwave ablation or radiofrequency ablation. I'm going to focus on liver today because it's just too much to talk about everything. The second is what we call a transarterial chemoembolization or a bland embolization. We'll go into detail on that in a little bit. The third is Y90 radioembolization. We do a lot of Y90 radioembolization in our practice at Mount Sinai. And then I would say fourth and fifth are what we call IRE, or Nano knife is the trade name. And then the last one is a new technology that's come about that a lot of people have been asking me, whether it's referring physicians or patients directly, which is Histotripsy or histosonics. It was just FDA approved this past year. And we'll go into a little bit of discussion on that, but there really isn't much evidence that has been generated from studies for that. I would say the first and foremost important thing when you're being treated for cancer is to see if you're being treated in a multidisciplinary team. Now, I put up a schematic for HCC, or primary liver cancer, but this certainly applies to all cancers in general. The reason a multidisciplinary team is important is because everyone brings their expertise to the table, and you're not of the mindset that if you go see a surgeon, most likely you're going to get surgery. If you go to a multidisciplinary team, everyone is going to weigh in on what they think is appropriate. And for instance, myself, an interventional radiologist, may think that local regional therapy is the best treatment for a patient, but someone else may offer up a different point of view. And I may say, oh, actually, that may be better for the patient. So to have all the tools for a patient to be treated, I think is very important. So the first technology we're going to talk about is thermal ablation. There are different technologies. Radiofrequency ablation has been around the longest, has generated a lot of evidence when it comes to this. And I'm going to talk in general speak because GIST falls under metastatic disease, and the principles are all the same, very similar. And GIST is an uncommon, as you know, disease, and so there isn't a lot of high-level evidence or large-scale studies that have been produced in terms of GIST and these technologies. Radiofrequency ablation, we're basically putting a needle or a probe into our target tissue, and then that emits wavelengths into the surrounding tissue. Those wavelengths, what it does is it agitates the molecules surrounding it. And when those molecules are agitated with enough speed, it causes friction. And that friction then causes heat. And that heat will then lead to what we call coagulative necrosis. It's very similar to a microwave oven where you put something into the oven, heat it up, and if you leave it in too long, it can get burnt. Our intention here is to burn the tissue or the tumor more precisely that we're going after. When we heat that up to above 50 degrees Celsius, it's called lethal heating. There's also just below 50 degrees Celsius, which causes sublethal heating, and we can exploit that to potentially either synergize it or combine it with other therapies, whether it's systemic or even other local regional therapies like bland embolization. This is just a movie to show thermal ablation in general alters the tissue. And this is what I just spoke about, where we put a needle directly into the liver. We usually do this under general anesthesia. And that's so that it's pain control, but it's also to control the breathing, because with breathing, there's movement of the liver. And then once those energies, as I said before, are emitted from that probe, it causes burning of that tissue. Now, when we use this technology, an important thing to keep in mind is patient selection. Not every individual, unfortunately, is eligible for a thermal ablation. When we look at all of the literature when it is in regards to metastatic disease, of which GIST is also involved, the ideal lesion is less than 3 centimeters in size. Ideally up to 3 lesions, but in certain disease states, up to 10 lesions can be performed. I would say that in general practice, it'll be up to 3 lesions. I think with multiple lesions, you're just putting a Band-Aid on a disease state. You're not really getting to the core. And if there's multiple lesions throughout both sides of the liver, you're just really just like a surgeon just cutting out what we see, but there's probably microscopic disease as well. An important factor when it comes to thermal ablation is that we need to get a margin around the tumor, very similar in principle to a surgical resection. Why? Because there's microscopic disease most likely around the tumor. And so we want to treat intentionally around the tumor so that we can also get that microscopic disease that we're not really seeing. So to get a 3 centimeter tumor to have a 1 centimeter margin, you're looking at a 5 centimeter ablation burn, which is what our devices are built for. So when you have an 8 centimeter tumor, you have to put in multiple probes and it gets a lot more complicated. It's not that it can't be done, but the efficacy of that goes down tremendously. And this is just a patient case where we had a 3 centimeter lesion in the right side of the liver. And then the image on the right is post-ablation, where we had a large burn with enough margin surrounding it. Now, depending on the location, shows how effective our ablation can be. If it's in a good location, it certainly rivals surgical resection. But if it's in a location that is unfavorable with heat sinks that minimize our technology, or more importantly, in dangerous locations where complications are known to occur, certainly it doesn't rival resection and it can be more dangerous. Now, microwave ablation, I think, has really taken the majority of thermal ablation in the United States anyway. And really, this is the same thing as radiofrequency ablation, but just much quicker to generate heat. So the technology is the same, but the ablation times are much quicker. So the physician can do a procedure, let's say in 5 to 10 minutes, instead of 20 minutes, 25 minutes. And this is just a study to show with a schematic with explanted tissue on the right, explanted meaning taken out of the patient, with a large burn that was done much more quickly than a radiofrequency ablation. This is just to show you a case that we typically do. There was a size of an increasing tumor in what we call the dome of the liver. It's relatively a difficult location to treat, but this was a solitary tumor about on the upper edge of 3 centimeters in size. And on the day of treatment, we couldn't see on the image on the left, our CT, the lesion, as clearly as we could on the MRI on the right. And you can see that there is this kind of round area that is a different color, a darker color than the surrounding tissue, which is the liver. And you don't see that tumor on the left image. So we use special equipment called co-registration. So we take the MRI and fuse it with the CT so that we can clearly see our target. And so this is just a video showing us fusing those two images together and using navigation, very similar to a navigation device in your car that you use to get from one place to another, with these yellow crosshairs demonstrating the needle here. And you can see as we're going along, our needle is getting closer to our target tissue, which is red. And then we intentionally create a margin, which is pink, around the tumor. And this is real time, very similar to the navigation device that you have in your car. This is a picture with our probe at our target. The yellow crosshair, it's like kind of like a video game, is our needle tip. And it's certainly at our target. And the blue crosshair means that you're exactly where you want to be. This is a 3-dimensional reconstruction of our needle, which is the yellow probe here, inside our target. And accuracy is very important for ablation. You want to be straight down the middle of the tumor whenever you can. This is our confirmatory scan, which shows that the needle is in position. And then we always obtain a scan with contrast afterwards to confirm that we have enough margin and the target was truly ablated. We then co-register those images together with our pre and our post procedure to demonstrate that all of the tumor was treated. And then more importantly, in this scan pre on the left, you can see the tumor here before treatment. And then after treatment, this is the ablation zone that is much larger, definitely enough margin, treated the tumor well, and the patient is doing quite well. Moving on to a transarterial chemoembolization or a bland embolization. What this is we go through the arteries in your body, which are like a network of roadways. And we take that roadway or artery that connects to your liver. Once we're in the liver, we then take pictures with contrast, which is a medium that we can see under X-rays, to find the roadways or the arteries that lead to the tumor. Once we find those tumors, we can then inject a drug and then block off the blood vessel. That is called chemoembolization. Embolization is blocking of blood vessels. Sometimes we feel that a drug may not be necessary. And in GIST, we may use bland embolization. That is just cutting off the blood vessel to the tumor. Now, the tumor has to obviously have blood supply from the artery for us to block it off. And GIST is one of those tumors that has what we call hypervascular or has blood supply going to it. And this is a video on the right of us injecting a tumor. And you can see that the tumor is what we call radiopaque under X-rays. our injection is showing the tumor, and we're blocking off that blood vessel to the tumor to starve it of its blood supply and cause necrosis. This is a study that shows that the higher the degree of uptake or blocking of the blood vessel with very small particles shows that it has a low recurrence rate if done properly. If it is not done properly, then there is a higher recurrence rate. Now, I will say that with these types of patients, when we do the embolization, the side effect profile is quite difficult to take sometimes. It usually takes 10 days or even up to a couple of weeks to recover because you get what we call post-embolic syndrome, where you feel nauseous, tired, and crampy type pain. And that's expected. It's similar to a muscle cramp where we've occluded the oxygenation and the blood flow to that area. And so you feel that crampy type pain afterwards. This is a 28-year-old male who had multifocal disease in the liver and had good underlying liver function, but was found to have multiple lesions. Now, when you look at this MRI, these white areas, kind of circles throughout these slices, indicate tumor. There are multiple tumors throughout the right side of the liver. Not very different from when metastatic GIST goes to the liver. So this is what we call our celiac angiography. This is where under X-rays, we use a tube called a catheter to get into that roadway or artery that I was talking about called the celiac artery. It leads to the spleen and to the liver. And to the left of this screen is going to the liver. And then we inject contrast in there, and it will help us see our roadways that we need to take. And so we can see that there are several feeding vessels to the liver. And then we do a cone beam CT or a CT-like image on the table. And this helps us to see for sure the tumors and to target them appropriately. And so here, just to point out, again, the background liver is really of a grayish nature. But you see these white areas, kind of circular or ovoid shape in nature. Those are tumors. And if we keep going, we see another one here. We see another one here. And then when we get up to the top where the patient had a resection, there are multiple tumors, most likely microscopic satellites that were there to begin with, along the edge of the liver that was resected. This is not uncommon. We use our software and we segment out these tumors. Here you can see 1, 2, 3, 4, 5, 6 tumors. And then we use a guidance software to show us exactly which vessels are feeding the tumors. This reduces the amount of radiation and increases the accuracy of our targeting. This has been proven with multiple studies that this is the state-of-the-art technology that should be utilized to treat tumors in the liver. Once we're in position, then we can inject our either drug or bland embolic into the area that's treated. Now, we want to get as close to the tumor as possible. Why? Because we don't want to affect the surrounding liver if at all possible. Our assumption is that this is really the site of tumor, and the other areas of the liver, we don't want to damage them if at all possible. We want to just get selective to the tumor itself. So this is us injecting our material. You can see we've successfully targeted 2 of our tumors. Again, we do a post scan afterwards. The pre on this particular image is on the right side. Again, you can see multiple tumors, about 6 tumors. And then on the left is our image to see if we had actually targeted it correctly. And so you can see we targeted this lesion post. And if we keep going, we also targeted this lesion, pre on the right, post, with uptake of our beads on the left. And again, this was also accurately targeted compared to the right. And then this cluster of tumors over here was also targeted appropriately from our therapy. And then if you see, we always get a 4-week follow-up with imaging. You can see the tumor markers have decreased. And those bright areas that we had previously seen are no longer bright, which means that the tumor is alive. But that previous area that we treated is now dark or black. And that shows that the tumor, I'm putting my pointer to the area where it was previously enhancing, has been well treated with our embolization. I talked about limitations of radiofrequency ablation. The ablative technique, microwave or radiofrequency ablation, shouldn't be performed in subcapsular HCC near the hilum. Location is very important. Near the heart or near the gallbladder or bowel, these can cause complications. And so in these types of situations, in our practice, we shy away from radiofrequency ablation, and we tend to do more radioembolization or Y90. This is a cartoon that shows what I just spoke about, arterial embolization, where we block off the blood vessels and starve the tumor. Radioembolization is different in the sense that they're much smaller particles, and we're seeding the area. We're just covering the area with these spheres that are embedded with radiation called yttrium-90. It only goes about 3 millimeters in soft tissue. And so it just stays in the liver. There's no harm or radiation that goes to people around you. The half-life is 64 hours. So by 2.5, 3 half-lives, or about 10 days, all the radiation has been dissipated. But the effects of the radiation can last for several weeks. And this is quite nice because that high dose of radiation is indiscriminate. It'll kill any type of tumor. You don't have to get the exact drug. It's a high dose of radiation. In solitary lesions, we see that it is a neurocurative disease therapy, meaning it rivals surgical resection and it rivals ablation. It can also treat larger tumors. There are studies to show it can treat up to 8 centimeters in size and maybe even larger tumors. It's very similar to a surgical resection where a surgeon would remove a portion of the liver where the tumor is and also get margins around it. We actually proved this through a prospective study of ours that was published in Lancet. Now, this is with primary liver cancer. But we looked at the tumor response, and we saw that 100% of the patients in this prospective study, meaning we're not looking back at our data, but we're generating data with 2-year follow-up, showed 100% of the patients responded, and 90% of the patients eventually had what we called a complete response, meaning all of the tumor was completely treated. We took some of this data, combined it with other institutions, and we found that when we gave a high dose to the tumor and those livers were removed either for resection or transplantation, the pathologists found that there was a 100% degree of what we call complete pathologic necrosis when we gave a very high dose. What does that all mean? It means that if we see a complete response on the imaging, most likely it represents a complete necrosis, or the tissue is dead, the tumor is dead. Now, that's important because imaging at the end of the day, like an MRI or a CT, is just that, it's imaging. So we think that it correlates with the tumor being dead, but it doesn't in certain instances all the time. With radioembolization, we know that there is an extremely high degree of correlation with pathology. This is another case just to demonstrate multifocal disease in an individual, meaning there are multiple lesions. These bright areas in the liver are tumor, and there are probably 8 to 9 tumors. This sequence on the bottom is what we call the hepatobiliary phase, and it shows functioning liver parenchyma as bright, and then the tumors as dark. And again, you can see at least 8 tumors within this scan. Radioembolization is very similar to chemoembolization in the sense that we use catheters or tubes to go into the arteries. And the same thing, we find a network of roadways to navigate to get to the tumor. And here We can see there is a vessel leading to the liver here, this dark kind of wavy pipe. And that's leading to multiple tumors, which are dark here. So 1, 2, 3, 4, 5, 6, 7, 8 tumors that we can see on this mapping study. Again, we used our embolization guidance with our cone beam CT, and it shows exactly which vessels are leading to which tumors. This helps reduce the amount of radiation and have us be exact with our placement of our catheters, because we want to spare as much background liver as possible and target really only the tumors. This particular case led to 4 injections with our Y90. And those 4 injections were because we wanted to target only the tumor and spare the background liver. We certainly confirmed that with our cone beam CT and made sure that we targeted all of the lesions correctly. And this patient on 2-year follow-up on the bottom and then imaging on top shows that they had a complete response. And more importantly, they showed on this delayed phase, again, the bright shows functioning liver. Pre on top, post on the bottom, shows that only the tumors were targeted and the background liver was healthy. And that's important because in this particular case, we're not going for cure. This was a palliative treatment, again, to extend life, but more importantly, to maintain the quality of life. And this patient was a computer software engineer, young individual, and still worked 2 years later and is now several years out. This is an important aspect because if we damage the background liver, then potentially you could go into liver failure. And this case is a patient with a large tumor, probably 8 centimeters in size on the right side of the liver. We also mapped this individual, treated him, and you can see that pre and 24 months later, we have a complete response. The tumor has shrunk to about 1.5 centimeters in size, and the left lobe of the liver is intact. The tumor markers dropped. Now, there is a lot of excitement with immunotherapy these days. And this is a study in liver cancer where they looked at the combination of immunotherapy and radioembolization in advanced disease for liver cancer. And what they found was that when you combine the two together, the patients did much better. And these were large tumors, about 8 centimeters in size, as opposed to doing immunotherapy alone. The median overall survival, again, thousands of patients that were looked at in the database, 20 months versus 10 months in terms of survival. 20 months with the combination of radioembolization and immunotherapy versus 10 months with immunotherapy alone. And this held true across multiple subclassifications. And this is just to show you one of those types of cases that we did where the whole right side of the liver and portions of the left are with tumor. This is that type of case where 70% of the liver is overtaken with tumor, but we decided to do a combination of radioembolization and a checkpoint inhibitor for this individual. And now they are 6 years out with normalized tumor markers. The right side is now atrophied from our radioembolization, and the checkpoint inhibitor also took its place in this patient, and there's no disease on the left side. Moving on to irreversible electroporation or nano knife. This is not the same as a thermal ablation, but what this does is it pulses electrical current into the target tissue. And what that does is it opens up the cellular membrane of the tumors and allows fluid to flood in and then destroy the tumor in that way. This has the advantage, potentially, as opposed to thermal ablation without causing heat and not having the disadvantages of heat associated with that.
System is the first to use
Now, this is a lesion that we treated near the colon. Now, I will say that we don't use irreversible electroporation all too much. This is about a 2.5 centimeter lesion, low in the liver, done many years ago, next to the colon. And you can see here, this is the lesion in the liver, a solitary lesion, and this is the colon right up against this lesion. And so thermal ablation, if we put it, it could heat up the colon and cause a devastating complication. So we use NanoKnife. We needed at least 3 needles from the NanoKnife or the IRE for this patient's treatment. You can see these are the 3 needles that are going into the target area. And then post, we had a complete treatment of that area. So you may think, well, why don't we just do NanoKnife for everything? It's an extremely long procedure and quite complex. And because you have to use multiple needles, when we do these procedures, the ribs and the respiratory motion and different factors make it a very long and cumbersome procedure. And for the anesthesiologist as well, there's what we call cardiac gating. So it's a very complex procedure, and it really hasn't taken off. It's been in the field for about 20 years. And I will say there's a handful of centers around the US that specialize in NanoKnife, but I would say that for the most part, it is primarily treated for pancreatic cancer in the operating room usually. Now, I will end with histotripsy, which is kind of the new kid on the block. It's also from the company Histosonics. Histotripsy is a non-invasive treatment for currently liver tumors using a robotic machine, and it targets high focused ultrasound. There is also another technology called HIFU, high intensity focused ultrasound, but this is different. HIFU also never took off because it takes an extremely long time to do. It hasn't been studied really in the liver. It's mostly in gynecology patients. But histotripsy, there was a Hope for Liver study that was done. It's a small cohort of patients, helped to get approval by the FDA this past January. And the machine is on the right. And so for those that are familiar with radiation oncology and external beam therapy or stereotactic beam radiotherapy, SBRT, it's also called CyberKnife. This is similar in its concept, except it doesn't use radiation. What it does is it uses ultrasound and focuses that ultrasound on a point within your body. And then if you see this histotripsy transducer here on this image on the left, but on the image on the left on the bottom right, it's multiple transducers that will focus that ultrasound energy into a specific spot. For those who have seen Star Wars and the Death Star, it's actually very similar in concept to the Death Star with that laser beam, except it's done with ultrasound waves. So a lot of patients have come to ask about histotripsy. We certainly are getting a device here at Mount Sinai. I would say that its applications are very niche right now. It is not created to treat multiple lesions, but currently to treat a single lesion at a time that takes about 20 to 30 minutes. And the maximum size of that lesion, ideally for that 20 to 30 minute time frame, is about 2 to 3 centimeters in size. The reason I say it's niche is that if I can ablate a lesion, I can do that in 15 minutes. And the evidence generated for ablation is overwhelming. It's thousands of articles that show the benefit of an ablation. So when would you use histotripsy? Well, there has been a lot of talk about using it as what we call an immunomodulator. Can it help other drugs that you're taking and maximize the effect of those drugs? It potentially can, but there's no evidence to support that it is actually doing that. There's no evidence or studies to show that it is actually doing that. And to be quite honest, there are multiple studies, as I just showed with radioembolization, with other technologies, ablation, blend embolization, radioembolization, external beam therapy in conjunction with systemic therapies to see if that's an immunomodulator. So certainly it's an option, but I would say it's not there yet. We just got approval for this therapy in January. So if you go to a center, most likely they only have a handful of cases that they've done, as opposed to potentially hundreds of cases with other technologies. But if those other technologies can't be applied, then potentially right now, histotripsy can be an option. It hasn't been proven in large tumors, which is mostly what patients are contacting me for, multiple lesions or large tumors. The evidence is not there yet for histotripsy. So to conclude and take some questions, local regional therapies. What is interventional oncology? Well, ablation in metastatic GIST, I would say, is for lesions 2 to 3 centimeters in size. We can certainly treat multiple lesions if they're small, and usually fewer leads to better outcomes. Why? Because of the nature of the disease, there's probably a lot of microscopic disease if there are multiple lesions throughout the liver. Radioembolization or radiation segmentectomy, extremely effective for hypervascular lesions. If there's communication between the tumor and the lungs, then it'll limit the effects of radioembolization, and you may not be able to receive it. And this is certainly the case that I've seen with GIST. We are writing up a manuscript right now and submitting it for publication with probably the highest experience with GIST in the country. We can certainly treat larger lesions with radioembolization. And we can also treat multifocal lesions as long as we have care to the background liver. Chemoembolization or bland embolization is cutting off the blood supply with or without a toxic drug. I would say that there is evidence to use it in GIST as well. We found in our experience, if we can do radioembolization, we'll do that first because the response rates, the duration of the response is much higher with radioembolization. IRE, there is certainly limited literature and not mainstream. Can theoretically be applied to GIST as well, but there are really no publications with IRE and GIST. Histotripsy is a new kid on the block, focused ultrasound. I would say that its main effect will be with solitary tumor, and limited in its application with most institutions. The immunomodulatory effect of combining it is promising, but the data isn't there just yet. Thank you, and I'm happy to take any questions.
Hey, thank you very much. This was absolutely fantastic. I believe that I learned a lot as well, as I'm sure many of the people who are on this call and who will be listening to the recording. I'm going to welcome participants to please submit your questions in the Q&A. But to just get started, we do have a number of patients who have successful Y90 procedures. And the question is there like a finite amount of procedures to have with this? Like, does it get less effective over time? And do patients who've had it previously run the risk of infection? If there's like, I don't know if there's damage to the liver or from the previous procedures.
Yeah, no, that's a very good question. I would say there is no easy answer to that because it depends on how it was delivered. Not all practices, I would say, go as selective, for instance, as our practice at Sinai. Some practices, let's say, may inject in a what we call low bar dose, the whole right side and then the whole left side. In those types of situations, I would say most likely you shouldn't get a second treatment. Why? Because most likely there could have been damage to the background liver. And if you were to do another treatment, that would cause more damage to the background liver. And that could not necessarily cause an infection, but more seriously cause liver compromise or worst case scenario, liver failure or cirrhosis. And so, again, as I stated in my lecture, we want to be good stewards and try and spare the background liver as much as possible. Now, in cases where we go selective, and let's say we treated, there are 8 segments to the liver. And let's say first time I treated a patient, I treated segment 4 and segment 8 and segment 7. And then a couple of years later, well, a new lesion pops up in segment 3 and segment 5. Well, those were areas that I didn't treat previously. Took care of the background liver. That person could get another Y90. And then if, again, a new lesion pops up, I assess how much functioning liver there is, and I can get selective to another lesion, then that person can undergo a third treatment. So it varies on how the procedure is done and how your background liver is functioning. Now, in certain cases where the recurrence is in a vessel that we can't get to safely with radioembolization, then we may have to switch and do a bland embolization. Or maybe we'll switch and do an ablation because the vessels aren't available, but the lesion that we're aiming for is, again, quite small or in a favorable location. So there are a lot of options. I think the nice thing about interventional radiology oncology is that we have a lot of tools in our armament to treat tumors.
Okay, so a lot more questions have come in. I'm going to try to segue into a question. It piggybacks to what you were just talking about, but it's like a triple questions. So first is, with the Y90, does healthy liver, background liver, typically rebound or grow back?
So if it has received radiation, I will say no. The targeted liver with the radiation generally won't rebound. What will rebound are areas that have not been treated with radiation. That's why if the whole liver has been treated with radiation, that there's no way for that to rebound. But if, let's say, I treated the whole right side of the liver, the left side can potentially rebound as long as it has good underlying liver function. Now, if you've undergone, obviously a resection of that left lobe and we're treating the right, then the left lobe won't, regenerate because it was removed. But also in instances where, let's say, you've undergone multiple chemotherapies, that is not without its consequence, as most of the individuals know on this webinar. Chemotherapy in and of itself can also damage the liver. And so I'm very careful when I have patients come to me and they've already received, let's say, 3 lines of chemotherapy. Then I'm a little more cautious in terms of how much liver I'm treating because I'll probably need more liver untouched by my therapy than less.
With the Y90 or any of the therapies likely to trigger an immune response that promotes tumor growth after the drug has left the system. We've heard this may be the case even open surgery.
It's all theory and speculation. Whether Y90 can have an effect on the systemic circulation to cause, let's say, something like an abscopal effect, where your body's immune system is triggered to attack the tumor. It depends. It depends on how much radiation was delivered. There are some theories out there citing that a lower dose of radiation can potentially cause an inflammatory response and trigger the immune system, as opposed to a high dose of radiation, which will just kill everything within it. When patients come to see me for treatment, if I can destroy the tumor, I'm going to destroy the tumor. I'm not going to give a sublethal dose because there may be a chance I can't go back in and retreat that individual. And we're speculating whether there's an immunomodulatory response. So it certainly can be and certainly can trigger a response, but it really hasn't been proven. The data seems to, from retrospective studies, point to that the combination may be good and it's certainly safe, but we don't know yet. And if the question is whether the Y90 will trigger the tumors to grow even further than previously, I would say probably not. There are instances where a large tumor may be emitting some type of cytokine or a signal to keep other tumors at bay. It's what I like to say is analogous, like a bully tumor, where a large tumor is just basically bullying all the tumors, and they haven't um, um, kind of declared themselves because this one tumor, for whatever reason, is emitting a signal, keeping those at bay. And then once you resect that, or you do a Y90 to it and destroy it, then all the other tumors come out of the woodwork. I would say that in certain disease states, we see that maybe less than 5% of the time. Again, GIST is so uncommon that we can't really speculate on that, but I would say that that's more common with primary liver cancer than I've seen with metastatic disease.
Okay, thank you. Do these treatments preclude you from having surgical resection if lesions become large enough for surgery to be necessary?
I would say no. In our institution, again, I lectured on how we use it as a not I mentioned it. I didn't really lecture on it, but we use Y90, for instance, as a neoadjuvant prior to surgery. Our surgeons will request it so that we can increase the liver size on the other side in the untreated area, and also maintain tumor control before they go in for a resection. There are certain places where the surgeons may not like Y90 prior to a resection. So it's going to be institutionally dependent. But I would say at places where there's a fair amount of Y90 that is done, surgeons will have no problem with it. And there has been multiple surgical consortiums that have come together just to discuss this fact, because some surgeons will say, oh, I can't do a surgery afterwards. And I think now the growing consensus among most surgeons are that it's not an issue.
Okay, interestingly that you talked about the neoadjuvant because somebody was asking about, are ablation and embolization more commonly used after medication treatment options are exhausted, or should they be considered earlier? She
Oh,
sort of,
that's a very good question. I think that is where the multidisciplinary team is so important, because obviously every individual is a different situation. Now, in our institution, we go by what is the stated literature. So right now, it would probably be systemic therapy in the setting of a metastatic disease. But after that first-line therapy, your options start to dwindle. The evidence is not so strong. So our referring physicians, our oncologists, tend to look to us earlier rather than later. The reason for that also is that I won't do locoregional therapies on patients who come to me in a salvage setting. Usually your liver is not functioning well, and your performance status, or how your energy levels on a day-to-day basis, are not great. In those situations, I don't think a locoregional therapy will help. And so usually we'll do it in conjunction with the first-line therapy, or most likely do it as a second-line therapy if surgical options are exhausted as well.
okay, great. There's a patient who is going to be going to their physician at the end of this week because they have tumors in their liver, metastatic disease. We're trying to best understand what are the type of questions I should be asking my physician when I go in regarding options. Do you have some suggested questions to arm them with?
Well, I would say broadly speaking, again, I can't emphasize enough. I would point blank ask, oh, are you functioning in a multidisciplinary team? Have you discussed this with the oncologist as well as the surgeon in terms of my options going forward? I would also ask the questions that have been asked here. Will the ablation or the embolization or the radioembolization have an effect on my background liver? Because I know that this is most likely not a cure. I think those are very important questions to ask. I would ask if there is potential to combine the locoregional therapy with systemic therapy, and will you speak with my medical oncologist on the possibility of that? So I think those are all good questions to ask. And then, of course, ask and set expectations in terms of recovery time. Will this affect my quality of life? Again, if you have a high burden of disease, I think sometimes doing no local regional therapy is beneficial because the local regional therapy may hurt you more than help you.
It just like many other cancers has different subtypes. So a patient wants to know if any or all these treatments could apply equally to a subset that's called sdh-deficient GIST.
Yeah, so I think a lot of subsets are, I think, more applicable when it comes to systemic therapy because of the targeting mechanisms of systemic agents. You can think of local regional therapy as being very similar or analogous to surgery. I mean, to put it crudely, we're maybe not as sophisticated as systemic therapies, which target at the micro level. We're like sometimes cavemen, where we're just cutting out things that we can see or treating things that we can see. And so, especially things like radioembolization, it's indiscriminate. It's like, again, very analogous to a surgical resection. So is ablation. If we can see it, we can target it, we'll most reliably destroy it. But at what expense is the question. So a lot of times, lesions that are, when you look at small studies, lesions that are resistant to chemotherapy or systemic therapy have better outcomes with surgery or local regional therapy because what we provide is indiscriminate. But again, it depends on the amount of tumor, et cetera. If there's a high burden of tumor, then local regional therapy won't help in that situation either.
Do you prefer MRI over CT? There is a concern about kidney and liver damage from CT contrast and radiation since having so many over the course of time.
I wouldn't be so concerned about the radiation when you have metastatic GIST or the contrast load. It certainly is something to be wary of, but getting the imaging is more important than worrying about that. But with that being said, I will 100% prefer MRI over CT. It just gives you so much more level of detail and information. It's more sensitive in detecting lesions and characterizing lesions. So if I have a choice, I will always ask, or I will schedule my patient for an MRI as opposed to a CT. And
Thank you.
MRI obviously has no radiation involved with it, but it is. I've been in an MRI machine. It's claustrophobic, so you have to deal with that. It is loud, and it does take much longer than a CT to perform. But if you can do that, I would recommend always getting an MRI for follow-up.
When tumors die off, does the liver repair itself or does this area become necrotic forever?
If the local regional therapy is done properly, it becomes necrotic forever. That, like I stated earlier, the areas that are untreated or untouched with local regional therapy, they can regenerate if necessary. It depends on how much volume of the liver is being treated. Generally speaking, if 40% or more is treated, then most likely your liver will have to compensate to regenerate portions of the liver. And as long as it's healthy, it can do that. Now, if you take a much larger percentage of the liver, like I said previously, maybe 50, 70%, then your liver may have a very hard time regenerating.
Okay, we have like 5 more questions and see if we can fit this in before you're cut off. If a
Yeah.
person was a candidate for any of these innovative treatments, would the patient need to stop medication like Gleevec before surgery and after? If so, what exactly would that time frame be?
I've spoken with several of my colleagues around the world. We are generally comfortable with keeping patients on Gleevec and performing local regional therapy.
Okay, about the Y90. Okay, had an extended left hepatectomy. They remove the liver will regenerate, won't the removed liver will regenerate, won't it? Also, can shoulder pain a year after Y90 be a result of the Y90? I don't know if you got
I
those
don't quite
questions.
understand the first question. If a liver was removed by resection or by even Y90, that part is gone forever and ever. So whatever is remaining has to regenerate. Shoulder pain could be a result of Y90 if it's near the dome of the liver on the right side, because the nerves that supply the capsule for there are the same nerves that also supply the diaphragm. So with breathing motion, potentially it could cause shoulder pain, but a year out is unlikely. By that time, all the inflammatory change has happened. But it's not beyond the realm of possibility for that to occur. Pain in general inside your body occurs because of stretching. It's not because of, stabbing or anything like that. So if your liver capsule is retracted or something, potentially it could cause pain.
Also, like just sort of a side effect, somebody asked if any of the therapies have a higher probability of leading to excessive bleeding.
The only one that would lead to potential bleeding is the ablation because you're directly sticking the liver. The transarterial therapies is no risk from bleeding from the tumor itself, bleeding from the access site potentially. But even the ablation, if done properly, you coagulate on the way back. But even then, there is a 1 to 3% chance of potential bleeding.
Okay, last question. Patient, metastatic GIST on Gleevec. Is there a time period when they should think about doing one of these procedures while on Gleevec and have that be investigated?
Yeah, it's really a discussion between the interventional radiologists and the medical oncologists. The presentations are all different. If it's, a small 3 centimeter tumor, 100%, you should think about doing a locoregional therapy. If there is multifocal disease on the right side, maybe. If there's multifocal disease on both sides of the liver with a large tumor and 70% of the liver, most likely not.
Okay, we fit a lot in because Dr. Kim has to go, but just want to thank you for the time today. Very informative. I think this is going to help many other patients who will see the recording as well. So just want to give you a big thank you for the time today and going through the 101 of local regional therapies. And thank you everybody for attending today. Take
Thank
care,
you.
everyone.
Thank you.